Atypical manifestation is something which is hitting all of us like an epidemic of sorts, and something we published a long time back in 2003. So I have no financial interest to declare. So as the world witnesses, in fact, massive increase in the incidence of diabetes, these unusual cases of diabetic retinopathy are being seen more commonly. And very often it is actually not just the diabetic retinopathy, with all these disorders that we are talking about today. The recognition is very often the first step in their management and treatment. So this atypical behavior of diabetic retinopathy, how is it manifest? In its inherent variability that one sees in the systemic and the ocular diseases that can morph or change the course or presentation of diabetic retinopathy and other miscellaneous factors that we look at. The inherent variability is manifest or exemplified in diabetic disc edemas, featureless retina. Diabetic retinopathy we think of as posterior pole disease, but you can have those abnormalities happening in the periphery too. The unusual course or pathway that diabetic retinopathy can take: fractional diabetic papillopathy, few Curio pieces like foveal new vessels, huge corneal spots. Diabetic papillopathy has been described as a transient, often bilateral edema in a young patient with good visual acuity typically, and with minimal background diabetic retinopathy changes. It's been called as the extension of the typical hallmark microangiopathy of the diabetic retinopathy onto the optic nerve head, and one needs to differentiate this from raised cranial tension, hypertensive retinopathy, new vessels of the disc. So a bilateral case can often be a papilledema, which is life-threatening as we all know and needs to be ruled out with neuroimaging. New vessels of the disc can also confuse us, but again, the haphazard arrangement of those new vessels on the disc and the intensive leak that will emanate eventually on the angiogram will differentiate that. Great for hypertension retinopathy. A simple BP assessment will rule that out. The debate diabetic papillopathy versus anterior ischemic optic neuropathy was initiated by Vapiad. NAION, or non-arthritic ischemic optic neuropathy, as we know, is the commonest cause of disc edema in elderly patients, irrespective of whether they're diabetic or not. It's associated, compared to diabetic papillopathy, with a greater visual field loss, deeper field defects, a relative afferent defect, sectoral hypoperfusion of the optic disc on the angiogram, and a poorer outcome on follow-up. There is an overlap in the spectrum of these diseases, and Dr. Hayre kind of gave us the counter to this argument and argued very vehemently against the existence of diabetic papillopathy at all. He called it non-entity. He said that all this was nothing but incipient form of AION. The case of AION with disc edema, unilateral disc edema, and a crowded disc in the other eye looks quite similar and can mimic diabetic papillopathy. So this is why the confusion is there. But eventually, usually, more often than not, diabetic papillopathy will resolve spontaneously, and you generally have a good outcome on follow with just control of the diabetic status itself. Featureless retina, this has been talked about by Ryan a long time back. Nothing but proliferative diabetic retinopathy, which masquerades as mild non-proliferative diabetic retinopathy. This is something which is a little dangerous, because sometimes you may just condemn these people to 6 months follow-up or even longer, and they can come back with big bleeds. So one needs to look for extensive capillary closure on the angiogram. No corneal spots, erymas, blotch hemorrhages are typically seen. What one needs to look at carefully is for these white thread-like arterioles, which are very often giveaways. On the angiogram, of course, you'll find capillary non-perfusion and new vessels. And this, again, to the casual eye, might look like a case of mild NPDR or moderate NPDR. But if one looks carefully, you'll find these white thread-like arterioles going nasally. And on the angiogram, you find this is nothing but high-risk PDR. Peripheral diabetic retinopathy, Nick et al. Found peripheral PDR in 2 to 3% of their cases. Han et al. Showed us that equatorial fibrovascular proliferations can lead on to peripheral TRDs. Terasaki found that in half their cases of peripheral PDR, they could find these oral fibrovascular ridges, and Ishibashi even demonstrated Curio vitreal neovascularization. Again, this, to the untrained eye, on a casual glance, one might think this is moderate NPDR, and if you look at the posterior pole angiogram, it looks like it is that indeed, but when we look at the angiogram in toto, you find that it's actually peripheral PDR, and you find the new vessels in the periphery. So you just don't have to look right only with a 90D or posterior pole microscopy. You have to look at the periphery too. Diabetic retinopathy can take an unusual course. Yuvan Pavard showed us florid diabetic retinopathy, which is a very rapidly progressive severe PDR in uncontrolled type 1 diabetics, and usually requires and mandates extensive panretinal photocoagulation and even early vitrectomy. Vandello found the opposite. a case of spontaneous regression of diabetic retinopathy in 3 type 1 diabetic women. And these people usually have stable blood sugar. This is rare, absolutely. And you can have a natural, spontaneous reperfusion of these non-perfusion areas. Few Curio pieces, Finkelstein and June showed us that new vessels can happen at the fovea also. You can have new vessels with the perifoveal ring, again in typically long-standing type 1 diabetics, PDR. Eggerer et al. Showed us that you can have massive cottonwool spots of the size of 2 to 4 disc diameters, and they usually have at their tail end a stenosis arteriole and a few collaterals popping up at that margin. Kroll et al. Was the first to talk about tractional diabetic papillopathy. It is nothing but vitreoretinal traction on the optic disc, resulting in pallor and a reversible visual loss once you relieve the traction. We'll look at a case that we've seen. This is a patient who came in with decent acuity, with a lot of hemorrhages, as you see here, centrifugal, moving out. If you look carefully at the optic, at the OCT, you find this incipient traction right there, slightly elevating the substance of the optic nerve head. It's just lifting that up. So that gave us a little clue, and surprisingly, within a couple of weeks, this patient came back with a fairly significant dramatic drop in vision. The patient was quite upset and came with, on the OCT, as you can see here, this mountainous elevation of the optic nerve head tissue and the stenting of the vitreous, as if the vitreous is just pulling up the substance of the optic nerve head. And this again, if a patient just presented this, a casual examination, one would be, couldn't be faulted for call this a proliferative diabetic retinopathy, which is hemorrhage. But if you look here very carefully, what you see here is these streaks of hemorrhage, which is basically the hemorrhage lining the folds of the posterior hyaloid as it tracks off the optic nerve head, and it's all funneling into the disc. And this hemorrhage is nothing but the breakage of the vessels of the optic nerve head tissue. So that's what's causing the bleed. And then surgery was done, vitrectomy was done, and you find that with just vitrectomy, 2 months post-op, acuity was resolved, and the picture improved dramatically with the restoration of the foveal contour. Systemic diseases can affect them of diabetic retinopathy, hyperlipidemia, carotid occlusive disease does so. Brown et al. Spoke to us about high serum lipids in lipemic retinopathy, seen in 2% of diabetic retinopathy cases. A milder variant of lipemia retinalis. It simulates a Coates-like response, and Amod Gupta in AJO told us how statins can reduce retinal exudates and ameliorate the picture. An example of a massive infiltration of the posterior pole with lipids, and you get this lipemic retinopathy. Carotid occlusive disease induces an asymmetric retinopathy. Gay Rosenbaum-Moss erroneously believes that it slowed down diabetic retinopathy, but actually it's the opposite. Duker, Dogru, and it all rightly believe that it worsens diabetic retinopathy, aggravating the ischemia, and the hallmark pathology is this ischemia. And when the stenosis exceeds 90%, you can even get what we all know as ocular ischemic syndrome. An example of an asymmetric diabetic retinopathy where you have very florid fractional detachment in one eye and very moderate NPDR in the other eye. So, which are the ocular diseases which slow down diabetic retinopathy or retard the progression of diabetic retinopathy? Myopia, glaucoma, optic atrophy being atrophic disorders, they do so by inducing a metabolic slowdown. They decrease the oxygen demand, decrease the VEGF release, and help slow down diabetic retinopathy. Extensive chorioretinal scarring, retinitis pigmentosa, these two do so by destroying those oxygen-hungry photoreceptors. Posterior vitreous detachment does so by removing that scaffold for new vessel growth. So new vessels don't have a platform to grow up. So that's how they slowed it down. Radiation retinopathy and parafoveal telangiectasia also alter the picture. Radiation retinopathy by aggravating the ischemia and inducing or triggering the hemorrhagic complications. You can see the huge amount of ischemia that your patient with radiation had. Parafoveal telangiectasia, you might confuse it with diabetic macular edema, but the presentation is quite clear, as Dr. Shukla has pointed out earlier. Asymmetric diabetes, then what does one look for? The definition given by Dogru was PDR in one eye and NPDR in the other eye, and stable thus for 2 years. One needs to first rule out ocular factors, mitigating factors, featureless retina, peripheral PDR, carotid insufficiency, and then rarely you might get this kind of a natural asymmetry in 5 to 10% of the cases. Again, but then one has to be careful before labeling it asymmetric DR. Look at this. Again, if you have to one quick look, you think this is an eye with vitreous hemorrhage here and the PDR and moderate NPDR in the other eye. But if one looks very carefully, you can find these fine new vessels, and when you look at it, the other eye also has PDR. So one should not be quick to label the other eye as a non-proliferative diabetic retinopathy. One still has to look very carefully, and then, if in doubt, go for an angiogram and err on the other side. So in summary, it is the recognition of these unusual features which helps us improve our diagnostic sensitivity, as we've seen in the case of featureless retina, helps throw new light on pathogenesis as with retinitis pigmentosa, helps modify medical treatment as lipemic diabetic retinopathy by behoving us to put in the statins, surgical treatment, and as in equatorial fibrovascular proliferation, helps avoid unnecessary treatment as with diabetic papillopathy and Parafoveal telangiectasia, and helps us institute early aggressive treatment where required as in florid PDR. Thank you.